Okay. Hello, everyone. Welcome. Thank you so much for writing into the chat where you're from and if this was your first time attending. But I'd like to welcome everyone to our weekly webinar series from Outro Health on drug-specific tapering protocols. I'm here today with Dr. Bryan Shapiro, our medical consultant here at Outro, and we could not be more excited to be speaking to you guys. Bryan will be leading the way through the presentation. I just want to welcome everyone in and say thank you for tuning in.
Welcome, everyone. Very excited to spend some time with all of you discussing a, uh, a very infamous antidepressant called Paxil. Myself, I'm a board-certified psychiatrist. My day job is uh, as an adult outpatient and also consultation liaison psychiatrist at UC Irvine Medical Center. But also, I'm involved with what we do here at Outro. And I think most relevant, for today, I think the topic hits home for me. I was treated on Paxil for about a year when I was very young for anxiety. And it's something where this was a very young age, maybe 7, 8 years old. And one of my early memories is having to go to my mom's bedroom where she would give me very small slivers of the Paxil pill. I remember how Paxil tastes. I remember it because I, my mom would say I had trouble getting off of it. I just wasn't myself. I followed the doctor's advice, and despite those recommendations, it was very difficult. I remember taking those slivers of pills for several months and eventually getting off, but that was a very early experience and kind of changed my orientation towards psychiatric drugs in general. So, very excited to discuss this topic today, and also wanted to introduce Emma, who really runs our growth and partnerships wing here at Outro.
Sure, I'll do a quick little spiel. Part of growth and partnerships here is also growing in terms of education and outreach so that potential patients, current patients, caregivers, family members, the curious, and even other providers and clinicians can better understand how to best support someone that is tapering, even if it is themselves. And that includes kind of kicking off these webinars that we did drug specific, and we'll hopefully be picking up to other topics moving forward. I'm going to be sending out a survey at the end of this webinar, or at least by tomorrow. And I'd love to get some feedback on different topics that we could also be covering that expand the educational needs and call for awareness and to action to help people feel as comfortable and safe as possible going through the tapering process, but also implementing other forms of wellness and taking care of themselves as, they're learning how to live life off medication. So that's me working on webinars. I do a bunch of other things here at Outro, generally in operations, but this is something that I really look forward to every week. And I'm very excited to get everyone's questions in the chat. So while Bryan is presenting, I encourage you all to communicate, get to know each other, and also send your questions in. I'll take note of them, and that can help us do a bit of like a rapid fire Q&A because Bryan has some patients to see right after this call. So we're going to make sure we do this in a timely manner. But with all that said, I think we're ready to get started.
So, turning to our agenda, and I do want to reinforce what makes these webinars very fun is and kind of personable is if you give your personal insights, personal questions that you have that are specific to you. We'd love to take some time, mostly towards the end of the webinar, to respond specifically to those questions. So, what we're going to talk about today are first of all, some general background kind of information about why patients might want to stop antidepressant treatment, the neurobiological basis for withdrawal symptoms, the tapering method that we use that's we believe should be standard of care, which is called hyperbolic tapering. We'll talk about nuances specific to this drug Paxil, and then we'll delve into some Q&A. So let's get started. So why deprescribe antidepressant drugs? First of all, just so you're aware, it is now 7% of American adults have taken antidepressants for at least 5 years. So clinical trials that kind of underlie the recommendations from psychiatrists, primary care doctors prescribing these drugs are based on short-term. These are short-term studies, typically 6 to 12 weeks, and they don't reflect. There is no real long-term efficacy and safety data for these drugs with long-term use. And with Prozac, having first been marketed around 1990, some patients are on these drugs for, over 30 years. And very often, these drugs are just continued by the prescribers without a tendency to revisit the need for them after life circumstances get a little bit better, questioning the diagnosis. Patients make progress in psychotherapy, and very often these drugs do not need to be continued. But there is this fear that stopping these drugs will cause a relapse, and that's something that I will also want to address. So we're seeing concerns from patients about being on the drugs long term, polypharmacy, where there can be synergistic or additive effects of taking multiple psychiatric drugs or psychiatric and medical drugs together. Patients often feel like they don't need to take the medications anymore because, again, life circumstances have changed. They've made progress in terms of their overall sense of self and their overall progress in addressing prior trauma or just overall progress made in things like cognitive behavioral therapy or something. Patients might just prefer to be off of the medication and not want to feel tethered to taking a drug every morning, which can be a burden and worry if you're going on vacation. How am I gonna? What happens if I, forget my medications, or can I get it in this other country or state? It can be concerning. Adverse effects, also, of course, this is probably the most common reason. And the way I describe antidepressants to patients when I'm prescribing them initially, when indicated, is that there are acute or short term transient side effects. And then there are long term side effects that tend to persist and not dissipate over time. And that those tend to be the side effects of the keyword is numbing, emotional numbing, sexual numbing, very common with these drugs. And looking at outro patients specifically, most of the time it's related to long-term effects. And even beyond numbing, we see patients with just this kind of low-grade kind of fatigue and just malaise and just lethargy that can be very insidious, very gradual in onset, because that's how these drugs tend to act. Is there's just very, very subtle changes over time. These medications also disrupt REM sleep like reliably, these SSRIs, and so there could be these very subtle effects that kind of accumulate over time. And we do find that patients off of these medications for whom really the drug was not indicated in the first place tend to do much better off of these medications as long as they're tapered appropriately. Not wanting to feel tethered to a medication, as I talked about. We talked about side effects, the interest in kind of taking a different stance in terms of mental health, looking at non-pharmacologic intervention, lifestyle, behavioral stuff that people need to feel well in an ever more stressful kind of environment that we live in today. And very often it's just a sense that, these drugs are not helpful anymore. Maybe they were helpful in the past, but I don't feel like I need these anymore, and I don't feel like they're helping. And so one of the major issues is that antidepressant dependence, withdrawal, chronic side effects, these are not topics that are taught or appreciated by psychiatrists, primary care physicians. And so very often patients will experience withdrawal symptoms when following a very standard taper protocol that might even be just, pretty standard guidance of these tapers that are a little bit over aggressive in our opinion. And so when the patient experiences withdrawal symptoms, maybe they have tingling in their body. They have this sense of tingling. They see their primary care doctor who prescribed their Paxil, and the prescriber is puzzled, baffled. You're at just 10 milligrams of Paxil. How could you be experiencing withdrawal? That's like a quote unquote homeopathic dose. And so patients go through extensive workups. We see this all the time. They go to the emergency room, urgent care, specialist visits without any answers. And so what patients out of necessity end up doing is they have to rely on online peer support communities communities of people who have experienced exactly what they have, or very similar to what they have in terms of their experience with supposedly trusted healthcare professionals. And these communities have really, I think, been a force for good in terms of substantiating and validating the need for these slow, gradual tapers. So it's really been a necessity, I think, because of the lack of education and awareness from healthcare professionals. Withdrawal is a huge challenge with stopping medications. More than half of patients experience withdrawal, and it really correlates with the duration of treatment. You might see here, based on observational data in this chart, where if you look at treatment duration on the x axis in terms of months, in the y axis, you see the percentage of patients experiencing withdrawal symptoms overall. You can see that it tends to be at least linear initially, and then tends to plateau, but only several years into of consistent use. So with the increased long term use of these medications, now 7% of adults have been on these antidepressants for 5 years or longer, which is a really uh, striking data point. Withdrawal is very, very common. It can be severe, debilitating, can lead to missed work days and all sorts of distress, unnecessary medical workup, and a lot of family strain as well. Symptoms can also be protracted, meaning they don't always resolve and abate within a week, couple weeks, or a month, especially if it's done too quickly and too abruptly. These withdrawal problems can be protracted and last months to even years, which is a situation that we want to avoid, but can also address as well. And the thing is that makes these mysterious to a lot of healthcare professionals is that, and kind of hard to detect, is that these symptoms are often very non-specific, meaning that the symptoms can be very just kind of general physical symptoms for which there can be multiple common etiologies. The symptoms can be cognitive, they can be psychological, so like mood related, physiological, physical, like nausea, dizziness, tingling sensations, irritability. They just span a lot of domains of the physical, cognitive, psychological domains. So there is one symptom that's Paxil applies here for Paxil as well. That is relatively specific for serotonin withdrawal, and that is brain zaps. So these are electric shock-like sensations that they feel like they're happening in your head, which is interesting. The brain has no sensory neurons, but it still feels like it's happening inside your head. That's usually worse when you turn your head. That's a more specific sign of serotonin withdrawal. Sometimes these usually correlate with the half-life of the medication, or as the drug is being eliminated from your body within hours to days of missing a dose. We usually see these quite reliably, but we do see in many patients that there can be a delay in the onset of these symptoms. Sometimes it can be a month, even longer. Typically and classically, it does resolve with immediate reinstatement of the drug. So the usual example is a person forgets to take their medication in the morning. They leave to work 4 hours later. They feel weird. They feel irritable. They feel just kind of a sense of malaise. They go back home, take their medication, and within 30 minutes or an hour, they start to feel the symptoms improve. But it doesn't always follow that pathway. And it's been very interesting to learn about the diversity of patient experiences in terms of withdrawal onset and symptomatology. So, what we do at Outro, we feel like it should be standard of care, but it's a novel technique, a novel, kind of in the last decade or so, and more recently, of hyperbolic tapering. And I'll get into this because it sounds like a very complicated sciencey term, but I'll break it down for you. But the foundation for this, I wrote about this in 2018, and Mark also is were these brain imaging studies. And what these brain imaging studies did was they looked at patients taking daily doses of SSRI antidepressants, and they looked at that for a given daily dose, how much of an effect it was having in terms of a percent occupancy, how much was it binding to this receptor target in the brain, the serotonin transporter, and mapping out a curve of how occupancy of that receptor correlates to the daily dose. So, and just briefly, we'll it was this hyperbolic curve. Basically, the important finding of these was twofold. The first was that minimum therapeutic dosages, and I'll be specific about Paxil here, 20 milligrams of Paxil correlates with an 80% effect on the receptor. So 80% activity. This is an average, but it's pretty consistent. So what that means is that within the therapeutic dosage range, let's say 20 to 60 milligrams of Paxil, as you go up from 20 to 30 to 40 to 50 to 60, the increases in occupancy are very marginal. It might go from 80 to 82% to 85% to 90%. But when you drop below the minimum therapeutic dose, when you go to 10, 5, even 2.5, still there's very considerable occupancy or effect on the receptor, 50, 60, 70%. So what that means in practical terms is that if you're a patient and you've been on Paxil 60 for, let's say, 20 years, and your primary care doctor or psychiatrist says, okay, we're going to go from 60 to 50 to 40 to 30 to 20, we'll even go to 10. We'll do this over 6 months, and then we'll stop at 10 milligrams. Sounds like a long taper. It sounds like a slow plan. You're stopping at a subtherapeutic dose. Patient experiences withdrawal symptoms, and they're puzzled. Well, following this hyperbolic model, the dosage needs to be much, much lower in order to substantially reduce occupancy to mitigate withdrawal symptoms. And if you have any questions about that, happy to parse it out. But it's kind of the model that we like to follow here at Outro. What causes withdrawal symptoms? So you have anytime your body has a set point, a kind of a comfort zone it likes to live in. And when you expose yourself to a substance, it could be a drug like alcohol, it could be a pharmaceutical drug like Paxil, your body over time adapts to it and achieves a new comfort zone where it does complicated things in terms of regulating receptors to kind of become comfortable with the exposure, the daily exposure to that substance. And so if you're on a substance for like 10 years, your body is very much adapted to it. So if you were to pull off the drug cold turkey, it's going to be very destabilizing for the body set point, and it's going to react pretty violently in terms of withdrawal symptoms. So what's important to do is, you can see this kind of in the B area here, is if you make slow reductions, then the disruption to the homeostatic set point, the comfort zone, is less substantial, and we expect that associated with that is less intense withdrawal symptoms. And so you can even take that further and make very, very small micro reductions. And we hope that we're actually going to minimally or even not at all disrupt the homeostatic set point to the extent that it would lead to withdrawal symptoms. So kind of minimize that by making these very, very small reductions. I want to talk a little bit about Paxil because, man, the Paxil, we learn in residency, the one thing we do learn about with antidepressant withdrawal, and it's not much, is that Paxil and Effexor usually have the highest risk. I think it's a little bit more broad than that. I think desvenlafaxine or Pristiq and also duloxetine Cymbalta belong alongside those and kind of form an overall top 4. But Paxil, I mean, there's a documentary in the UK about Paxil a long time ago. It's notorious in terms of withdrawal symptoms, and it's a very, very potent serotonin reuptake inhibitor. So it binds very, very tightly to the serotonin transporter. It does have some off-target effects. It has some modest anticholinergic effects, and this is one of the reasons why there might be a little bit more of a push to taper Paxil, especially at an older age, because there's recent prospective data suggesting that anticholinergic drugs or exposure to these drugs long-term can increase the risk of cognitive impairment and possibly dementia. And so it does also have some mild noradrenergic effects. So it has a little bit of a SNRI kind of function. And the way I think about these drugs is that the more receptors you're occupying, the more targets that you're withdrawing from. So that you have the chance for, it leads to more severe withdrawal. It also does have a short half-life of less than a day, which correlates with withdrawal risk. There's There's been some.
Yeah, in the chat actually asked what was the name of the documentary that you mentioned.
It's called Secrets of Seroxat, which is the branded name for paroxetine. I'm not sure if it's actually freely available. I think it was BBC. So there have been a lot of comparative studies, early studies comparing the withdrawal risk of Paxil to Prozac and Zoloft, and Paxil had a relatively higher incidence. It's one of the few areas where you actually see head-to-head studies of these antidepressants. Was in those early studies looking at withdrawal. Fortunately, the good thing about paroxetine is that there is a commercially available liquid formulation. And so the magic of liquid formulations is that they enable individualized dosages. So you can achieve dosages that are in between conventional dosages. And also it enables very careful subtherapeutic dosages. So very, very small dosage amounts to help make the taper process a little bit more slow and mitigate withdrawal symptoms. So that's a real positive and a plus for patients tapering off of Paxil. And so getting back to this hyperbolic tapering step, I kind of described this, but just looking visually at the curve for Paxil, this is a daily dose of Paxil on the x-axis. 20 milligrams is considered a minimum effective dose for depression, and this is the overall activity at the receptor. You can see that even at the minimum therapeutic dose, correlates with about 80% occupancy of the transporter. And even if you're at 10 milligrams or even at 5 milligrams, you're still occupying 50 to 60% of the transporter. So very common for us at Outro to taper patients to 1 milligram or less of Paxil before we're ready to jump off and trial discontinuation. We do stratify withdrawal risk. I'm not going to spend too much on this slide, but usually our tapers are a little bit more quick than this, at least. So a medium would typically be more along the lines of like a 10% reduction. So 10% reduction being like we go from 10 milligrams of Paxil to 9 milligrams of Paxil. Kind of a faster version would be more like 25% reductions. And these are reductions carried forward is what we like to do. So we go from 10 milligrams to 7.5 milligrams would be a 25% reduction. We would do 25% of 7.5, not another 2.5 milligram reduction. But with Paxil, it's not unusual for us to make 5% monthly reductions because we're so cautious and concerned about Paxil specifically. So going from 10 maybe to 9.5. And this is a process that can take a lot of time. But in very vulnerable, sensitive patients who've had their lives truly devastated by withdrawal symptoms and who have been on these medications for 20, 30 years, we feel like this is actually makes a lot of sense and I think is a necessary step for many folks. So I know we're kind of moving a little quickly, but we're going to spend a lot of time on the Q&A, but wanted to spend a little bit of time on Paxil specifically. So what is Paxil approved for? This is actually a question that I don't actually like to, I don't put too much care to because it's really just a matter of whether the pharmaceutical company decided to do the studies for those additional indications. Any of these SSRIs are so pharmacologically similar that they're going to be effective for conditions ranging from MDD, GAD, PTSD, premenstrual dysphoric disorder, obsessive compulsive disorder. They're all going to be essentially equally efficacious and indicated for those conditions. Paxil may have an indication for certainly MDD, but maybe a PTSD as well. So there are, unlike the SNRIs, it's not often used for like neurologic symptoms, like headaches, diabetic peripheral neuropathy. It's not usually used for those non-psychological indications. It's sometimes prescribed for, actually even today, for premature ejaculation in men because probably it more reliably causes orgasm issues and sexual dysfunction than treats depression. So it's very commonly used for this, honestly, and the data supports that. So very commonly used for that purpose. And you can imagine I talked about this for Cymbalta, whenever a drug is being prescribed by a non-psychiatrist, I mean, even psychiatrists, but non-psychiatrists or for non-psychiatric reasons, there's less likelihood of a proper informed consent process that discusses the risk of dependence and withdrawal. What about if you didn't experience side effects starting Paxil, is this indicative, is this suggestive that I won't experience withdrawal? And that's an interesting point because for whatever reason, and in my experience, 10 to 20% of patients will experience acute symptoms when starting Paxil, like initially. For whatever reason, it's the body tolerates better going from 0 to 80% or 0 to 60% occupancy or activity compared to 80 to 0. There's something that when these drugs take a hold of the brain, it's much, much harder to come off of them. So I don't think this is a reliable predictor of withdrawal symptom severity, whether you have whether the absence or presence of significant side effects of these drugs.
Just before we continue, I think that something that's unique or interesting to this point for antidepressant tapering that I think also has to do with, if you're experiencing side effects coming on, does it mean whether or not you'll experience side effects coming off or withdrawal symptoms as you're coming off? Is also maybe discussing a bit more about like the general risk factors for experiencing withdrawal. Bryan, if you could expand on that a little bit.
Yeah. So let's talk about general risk factors for antidepressant withdrawal. And this can be divided sort of in risk factors that are related to the drug itself and kind of patient-specific risk factors, right? So related to the drug itself relates often to the half-life of the drug. So the lower the half-life or the time it takes to eliminate half of the drug, the lower half-life is usually suggestive of more severe withdrawal symptoms. Multiple receptor targets, as I mentioned before. So with Paxil affecting acetylcholine receptors, norepinephrine transporter, as well as very tight binding and high affinity potency for the serotonin transporter, more likely to be associated with withdrawal issues. Third, I should say, is the dosage formulary of the drug. So Cymbalta, for instance, is a drug that you can't even make a liquid formulation because of certain properties. Drugs that have more limited dosage formularies are much more difficult to taper, which is why it's so crucial at Outro that we contract closely and work with compounding pharmacies that can essentially require any dosage of any psychiatric drug, which is essential and obviates and overcomes the challenges and limitations with these drug formularies. We really that is a really essential part of the taper process. There are patient-centered factors as well, and these are a little bit more idiosyncratic and kind of a little bit less tangible. For me, a predictor of a patient's withdrawal severity and something I use to gauge the pace of the taper is, I ask the patient if they've ever missed a dose of their medication and how they felt. And sometimes there can be delayed onsets or situations where a patient might not experience it. But a pretty good gauge for me is I ask a patient usually has a very vivid memory of forgetting their medication when they went on vacation, or forgetting to take it in the morning and having significant noticeable reactions. That's a little bit of a marker, that little trick that I use when I'm talking to patients to help gauge their overall vulnerability to withdrawal. Another factor is, of course, duration of use, the duration in which the patient is used, taking the drug, as well as we can't neglect the effect of stress. Patients with high burdens of environmental stress, situational stress, are more likely to be sensitive to withdrawal and deviations from their kind of comfort zone, their set point, because their nervous system can become sensitized in those stressful situations. It's kind of a mix of patient-related factors and environmental factors, and also drug-related factors that can be pretty predictive. Although it's not a perfect kind of predictor, but there are some markers that are useful. Emma, I haven't heard of, and I do a lot. I haven't heard of Paxil eyes.
Oh, this is like it's like a pupil dilation, but it's like really intense. So this was something that I actually heard when I was in college, like thrown around. So I added it in here just to see if it was something that was maybe more of like the college generation type of communication, if that was more of just the lingo or jargon. But, they have terms for other medications of the way it essentially even changes your demeanor or the way that you can be present in a conversation. And that widening and dilation of the pupils also has more to do with like the lights on, no one's home. I heard specifically Paxil eyes my junior year of college. So I thought, if not now, when to bring it up into this conversation?
Yeah, well, the first thing that when you said pupil dilation, I'm like, okay, physiological effects of Paxil in terms of these anticholinergic anticholinergic effects or cholinergic rebound on withdrawal, might explain that. But then I'm kind of thinking about people who feel numbed and apathetic on these drugs and feeling like they're not really present in the moment and there, kind of with you because they're really numbed by the chronic use of these drugs. So I think it rings true in a couple different ways. So, is there a biological explanation behind calling Paxil the most powerful antidepressant? So, I suppose, Paxil has the highest affinity or binding affinity, meaning it binds more tightly to the serotonin transporter than essentially all other serotonin reuptake inhibitors. I suppose potent might be, you call it potent. Powerful. That's, I think, to me more suggestive of like effectiveness. We've known for a long time that all of these drugs are considered equally viable or equally effective for the conditions they're touted to treat. No distinction here in terms of effectiveness, but I think there's a clear signal that Paxil has a greater side effect burden. There was some early data. It was industry sponsored, of course, but suggesting that paroxetine had more weight gain than fluoxetine does. This was an Eli, of course, an Eli Lilly, the manufacturers of fluoxetine and Prozac, but showed that the rival competitor Paxil had more weight gain. There was FDA warnings for teratogenicity or birth defects associated with paroxetine use. Things like persistent pulmonary hypertension and cardiac malformations and stuff like that was a concern. There has been a concern with Paxil for women of childbearing age. So it's something we are concerned about in that population. And then before, when we used to use pregnancy categories, like some drugs, category C or B or D, Paxil was a category D. It had a less favorable, a less preferred in pregnancy due to those concerns that I just mentioned. So, Emma, do you want to talk a little bit about how we do an outro?
Yeah. Am I unmuted? Yes. Actually, Mary just wrote this in the chat, so I'm glad that we're transitioning over. So when people might hear tapering clinic, depends on how familiar they are with the intricacies of what it means to taper or being in a clinic. But they might think that it's just medication management. And outro is a bit more than that. And I think something else that we do that's really unique, I mean, it's very multifaceted, but the things that we do that are really unique is there's this emphasis on recentering your health back on you and what it is that you want and what your needs are and what your goals are. Because coming off an antidepressant, the first decision that you make by coming to us is what is one of the most important ones, because we're here to kind of walk you through that process, not just maintaining and supporting you in terms of reducing the dose medication, but also in monitoring how the burden of withdrawal has been affecting your day to day, new symptoms that are coming up, old symptoms that have since no longer persist because of the change in maybe your dose plan, the relationship that you developed with your clinician that is going to be really different than your typical experiences or a lot of people's experiences in the past, because these clinicians are here to validate your experience specifically about the withdrawal symptoms. People in the chat for every webinar are always talking about how they had no idea when they see the list of withdrawal symptoms. Oh, I ended up going to so many other, I was referred to a neurologist or to a gastrointestinal doctor or all these other problems. I had no idea it was withdrawal. And I think something really unique about Outro that makes it more than a medication management clinic is that we're here to validate the experience and help you identify and champion strength in coming off the medication, because it's not just about writing you a prescription and meeting up with you, seeing you once a month. It's also about, gauging your emotional, physical, and psychological check-ins as you can journal throughout the experience and write them to your clinician. And also, again, tracking those withdrawal symptoms and the opportunity to also message with your clinicians between appointments and having access to the best in class, people like Dr. Bryan Shapiro and people like Dr. Mark Horowitz, like our incredible clinical team that are really here to support you, see you, validate you, and help you get through this process. Moving forward, there's other opportunities to help us build out a referral system for connecting you with therapists that are in your states, or, acupuncturists, nutritionists, health coaches, things of that nature that can also help you feel supported. And those will be people that can also tune into these webinars, gain access to educational material, and be trained on becoming taper friendly so that they can also help support you through this process. Maybe with bias, we're more than just a tapering clinic. On that note, Bryan, if you want, I can also continue here. Actually, this pretty much sums up what I was talking about earlier. So you go through this onboarding process. You have your initial consultation, which is 15 minutes. And that's a great opportunity for you to get to meet your clinician, build a bit of rapport, and have, maybe even for the first time, someone hear your story and be nodding their head in agreement instead of, disagreeing or not invalidating, minimizing what the human experience has been for you and trying to come off these beds, or the side effects of being on them for, a long period of time. And then you kick off your taper initiation and you continue with the follow-ups up until you completely discontinue successfully off your antidepressant or antidepressants, depending on, your polypharmacy. If there are more questions, we'll cover them in the Q&A for this, but just so we can, So here are the states we're in. Mark normally asks me to go through these because he doesn't know the US states as well as I do. So I guess I'm accredited that. But right now we're in Washington, California, Texas, Colorado, Florida, and very recently New York. And we're going to be expanding, but this is where we are for now. And for many of you that are working with us, it's been great so far, and we're going to be continuing to grow. Okay, we made it to where I was hoping to get to. Fantastic. Okay. So I did keep track while I was talking. I wasn't able to keep track of the chat, but I do have a list of questions that people wrote throughout the presentation that Dr. Shapiro incredibly gave and walked us through. So I'm going to start shooting off some questions for Bryan. And if anything else comes up, or if you sent anything in the last 5 or 6 minutes, just resend it in the chat. It happens. So Bryan, a question that comes up pretty often on our webinars is about reinstatement. And I know there's not a one size fits all answer, but largely what can you say for people that are currently in reinstatement and they're feeling less of their withdrawal symptoms that they were feeling, before they started their reinstatement? So they're coming more to like a baseline. How long after they are at baseline, where their withdrawal symptoms aren't so burdensome, do you normally suggest, again, it's not a one size fits all, do you normally suggest that people can start tapering again?
Yeah, and there are all sorts of shades of gray. So some patients, they reinstate and they don't feel better relatively quickly. Some feel a little better and some feel all the way better. We recommend after a month or two of stabilization. So maybe like after they start to feel better, maybe about a month later, we're gonna taper, but we're gonna do it more slowly than previously attempted, to make sure that we avoid those withdrawal symptoms that made the process so difficult. We do in some cases, what a stable mean. So if the symptoms are 2 out of 10 or less is normally where I might feel comfortable giving it another go. For folks who maybe have reinstated and don't feel better, really important just to give it time. It can be, again, that disruption to the comfort zone, that homeostatic set point. It can take a little bit of time to recover. It can kind of set the nervous system off and it needs to kind of take time to calm down. So we wouldn't recommend starting the taper until the body sort of settles down. And for the patient, that means taking those lifestyle behavioral steps to reinforce this sense of safety and calm and make sure that everything else is lined up to give yourself the best possible chances to get to feel better more quickly and stabilize more quickly before we try a more gradual taper.
You had also mentioned that you were going to answer Christina's question about cross tapering.
Yes.
Great. This is a good.
So we don't need to. It is an we don't. It is an option because again, these SSRIs have a lot of overlap, and Prozac does have the long half life. But we don't like to resort to that at outro because first of all, there can be potential differences that are individual and subtle between how a person metabolizes Paxil and how a person metabolizes Prozac. The pathways are a little bit different, and so there's not always um, a clear, or we have to kind of transition from one to the other based on averages and not based on an individual. So the purest kind of way to do it, or the way I advocate it, because we have a compounding pharmacy, is just stick with the drug that you're taking because that's what your body is most used to, and just taper off of that one without introducing new variables to the equation.
Okay, sorry, I'm reading through all the notes. Heather asked, are withdrawal symptoms more pronounced as you decrease in dose as you're tapering? Is it more likely that you experience an increase in withdrawal symptoms?
Yeah, it's a great question. I just want to refer back to a little slide here, which really highlights this point. Is you can imagine if this curve were to be extended, this is still within the therapeutic dosage range. Up to 60 milligrams of Paxil here, it's going to be pretty flat. But the withdrawal symptom risk correlates on average with the steepness of the decline in the curve, which you see it becomes more and more steep the further and further you go down, if that makes sense.
So in her case, it was the question of withdrawal symptoms specifically as you're getting to 5 milligrams or less.
Right. So 5 milligrams or less might sound like a very low dose. It is 1/4 of the minimum therapeutic dose. So like 1/4 of the minimum therapeutic dose. I mean, what is that doing? Well, 50% of what of what a maximally saturated Paxil would do. So it's a lot. It's a big effect. So you want to take that 5 and you want to push it further down, down to probably a milligram or less of the Paxil.
And Lindsay is a therapist, and she's a therapist slash person. Great. She actually, it's not a question, but it's a really interesting point. I'd love to hear your thoughts on this. As a therapist slash person who's been on SSRIs, it's interesting to see how there seems to be trends. The meds I hear about people being prescribed now are different than 10 years ago. Example, my friend is on Paxil and has been on for 10 years now, but now I've never heard of anyone being prescribed it.
Exactly. There's the influence of pharmaceutical companies, of culture, of So, in my opinion, Paxil is an outdated drug. I don't start it for patients. I would never start it on because there are alternatives that. The one thing I didn't mention is that Paxil has the highest tendency of drug-drug interactions among SSRIs. As a strong, it strongly influences the certain metabolic enzyme in the liver called CYP2D6. It has off-target effects, anticholinergic effects. It has more side effects, potential for weight gain, severe withdrawal. There's no reason to prescribe it. Now, there was some lore a long time ago when I think Paxil was, GSK, or they were trying to get a market share of this drug against rivals like Prozac, which is that Paxil is better for anxiety than other SSRIs, which is not founded in the evidence whatsoever. So there are shifts in kind of perception, and as these cleaner options become quote unquote cleaner options, more selective options became generic. There's these older options like paroxetine just became kind of defunct and less commonly prescribed.
I think that covers most of the questions here. If anyone wants to pop in any final thoughts.
Oh, Selma made a great point. One of the ways that Paxil interacts with these other drugs is with antihypertensives, which are metabolized by this CYP2D6 enzyme that I talked about. So it can really affect levels of these drugs, increasing levels of drugs like metoprolol, which you mentioned. And another reason that very often it's indicated to come off of Paxil long term. And Christina, we did talk about liquid Paxil. I think it's a necessary part of Paxil taper because again, it allows you to achieve those intermediate dosages or sub-therapeutic dosages. And fortunately for Paxil, there's a commercially available liquid formulation. You don't have to get it compounded at all. You can pick it up from the pharmacy and kind of use that to. It's an affordable option to achieve those other dosages.
We actually get this in the webinars pretty often too. Jamie's last point about people that might struggle a bit transitioning off of tablets to liquids. Is that typical across all antidepressants, or is it in a case by case for specific formularies?
So all of the formularies of SSRIs, the tablet and capsule based formulary, are very limited.
Mm-hmm.
So you cannot taper in a way that we recommend these SSRIs using just the tablet and capsules, even for sertraline, which you can actually just break the tablets down to 12.5 milligrams. Even that is not, it's not slow enough. All SSRIs except for fluvoxamine are available in a liquid form,
Mm-hmm.
and it's the approach that we suggest. If but again, you have to measure liquids, and some patients would prefer the expense of getting a compounded capsule where they just pop a pill of the lower dose and take that every month. So it's a matter of preference. It's cost versus convenience.
Well,
Pedro asks, how can you increase serotonin production during tapering to offset reduction in serooccupancy? I don't recommend doing that. So there are supplements like 5-HTP, L-tryptophan, St. John's wort.
mm,
If you need to increase serotonin production during tapering because you're having withdrawal symptoms, it's suggestive that you didn't go slow enough. So we wouldn't introduce new variables, and we would just make sure that the taper is at an appropriate pace to not incur withdrawal symptoms.
have you seen alcohol or caffeine having any impact on tapering?
So it's a good question. What we recommend is to not significantly change caffeine or alcohol use actually during a taper, to not introduce new variables. We don't want someone who's withdrawing from alcohol because it's going to confound
Well
our
said.
interpretation of the taper.
Mhm.
We do want to make sure that the use is at least not excessive.
It's at bay, moderate.
If there's heavy drinking, then they need to address that first before we taper. If the caffeine use is excessive, maybe they can get by without significant withdrawal of just reducing it to a little bit of a more normal amount. But we're careful about these other extraneous factors that could influence not only the taper success, but also our ability to manage the taper correctly.
Well said. And on that note, do you think you can respond to Rebecca's comment on her site recommending that she microdoses shrooms to get off Paxil?
Nah, I
Yeah,
uh,
I
I
didn't think
can't
so.
advocate that for that in good faith. There's too many unknowns. The point is that we don't recommend any need for any additional pharmacologic intervention or supplement based intervention for patients who are tapering. The most effective and clean way to do it is just to taper the drug without introducing new variables.
Well said. Don't change too many variables at the same time. Keep it controlled. Lindsay asked another great question. As a therapist, anything I should watch out for, suggestions on ways to support clients with tapering? Before Bryan answers, I just want to plug that we're doing a tapering webinar specifically tailored to therapists on the 24th of June. So, Lindsay, I encourage you to go back to our Luma page and register for that. Megan Cornish, an incredible therapist, will be co-hosting with Dr. Mark Horowitz and actually speaking on this exact topic, how to best advocate for your patient throughout the process, the tapering process. But if Bryan, if you have any commentary as well on it, I just want to shamelessly plug our webinar events.
Yeah, so what a therapist can do, first and foremost, in my opinion, is behavioral activation. So making sure that they are engaging in activities and not putting them in a position where they're going to be left ruminating about physical sensations in their body. So staying active to the extent possible, making sure they're engaging in all parts of their life, occupationally, keeping busy is very, very, very important. Um, making so basic principles of cognitive behavioral therapy. So kind of catastrophic thinking in terms of sensations or fear, like I'm never going to be able to get off this drug. Like thinking in worst case scenarios can sensitize the body, sensitize the nervous system, and increase distress, and is overall not helpful. So kind of the CBT side of things, behavioral activation, supportive therapy, just general lifestyle modification and validation during what can be a very difficult process. Even if done perfectly, it's a slow process, and there can be some trauma that comes from the harm that's been done. So those sorts of things.
Just dropping the therapist webinar. I think this is a good place to stop because Bryan has some important patients to see. And I just want to thank everyone for attending. Thank Bryan for making time for us today. And I think on that note, we're going to close off. Bye.